welcome back Miss Sue Dumas, Debbie Condino, Andy Brown, and Lindsay Parton to talk about the Macomb Outreach Program again.
Well, we talked a little bit before about one of the challenging parts of the program is just gaining the trust of the survivor and family. Have you found, before you give us an overview of the program, have you found that to be true for you as well?
Gaining the trust of, yes, the survivor and his family is basically, that's what I do upon approach to the home, to make sure obviously myself and the team is safe. So yes, getting the trust right off the bat and basically gauging how the visit's going to go is very important.
So from a law enforcement perspective, can you give us an overview of what you do and about the program?
About the program, so the Macomb County Outreach Program basically recognizes that law enforcement has a front row seat to the opiate epidemic. This program provides training, strategic guidance, support, and resources to help survivors and their loved ones create pathways to treatment and recovery. This is a non-arrest program. Therefore, we are diverting people away from the criminal justice system. The residents that we're going to go to, I vet it for safety prior to arrival. And then as getting to the house, I greet us. I introduce the team members, we usually by first name, and then what entity they represent. So it kind of looks like, hi, usually this is Lindsay from CARE, this is Nikki from MedStar, and then usually I just say, hi, I'm Sue. And then I gauge at that point in time how the visit's going to go. Are we getting smiles? Are we getting invited in the home? Are we getting recepted? So usually 98% of the time we're getting really great acceptance, invited into the house, and it goes pretty well.
Well, that's good. That's good to hear. This program is just fascinating to me. When you introduced the initiative, how did that work, and how long ago was it? Like, who did you have to send it to?
Back in 2019, Debbie Condino obviously went to our Sheriff Anthony Wickersham, and got the acceptance to be part of this program. And he was ecstatic, of course, and always willing to help the community. So at the time that I was chosen to be a part of this program, obviously by the sheriff, and Debbie Condino arranged for a few of us to go out to Washington, D.C., where they were actually holding a conference on how to actually run this program.
So that was probably really helpful training.
It was very helpful. We got a lot of networking done, got to meet other people from other departments, got to speak one-on-one with a lot of people that started this program out in Massachusetts. It was a wonderful experience.
Good. Well, does Macomb County do anything different? And like, did you just take all of their ideas and mesh them into what we have or what you have in Macomb County?
Well, you want to go with what works, and Massachusetts, it works. So yes, we got some materials from them emailed over to us, and we followed their guidelines as best as we could because we know their program is very successful out there. So they gave us scenarios. They told us how to approach the door. We actually did a lot of training before we actually went out on our first visit. We practiced dialogue, what we were going to say to when we went there, and different things like that. So the team members practiced before we went out. How to do the approach, how to act, questions to ask, how to gain acceptance and things like that. So yeah, we pretty much followed their program to the T.
And if I just may add, Sherry, what makes it unique, just add to what Sue was saying, because it is true, the law enforcement piece we copied, and because honestly, there was doubt on my part and actually others that we would be able to pull this off with law enforcement because, as you know, the people that we cared for usually have a different relationship with law enforcement. And we also learned, I think I shared a little bit yesterday, that they have a different relationship with law enforcement, and this would be different. This would be introducing and asking for more trust because they don't trust people in uniforms, as I said yesterday. And so that's what we kind of hesitated involving law enforcement. However, that dimension to this group has changed everything, I think. It has created a different relationship. It has built more trust. There is a knowledge of our program and actually less fear, less fear of the police, but more trust in law enforcement. So it's been interesting. But what makes this unique, our program, is the medical piece, the piece with the community paramedic actually doing on-time, real-time providing medical care if it's needed. And again, they also are people who wear uniforms. People in healthcare wear uniforms. And that's why they go pretty casually too, because honestly, there was a different relationship with healthcare providers. So that's what has been very, very different.
Thank you. Thank you for that clarification. So, Sue, you've been on a lot of different visits. What do you think is the most rewarding part of this program?
The most rewarding part is to see Nikki and Lindsay getting hugs at the end. Is the most rewarding part. Hearing things like, I was at my wit's end today. I didn't know how I was either going to help myself or help my family member through this really hard time that we're going through. So it was like one of those, everything happens for a reason. And here we are standing on your porch today. And that's what they'll say to us is, I didn't know where to go today. I didn't know what to turn. And then all of a sudden, Nikki and Lindsay will be looking at them and going, that's why we're here. That's why we just happen to be on your doorstep today and show up here so we can help you get help. So that is, and we get a lot of tears and the girls get a lot of hugs. And that's most rewarding for me. And then to get the feedback from Lindsay that these people have signed up for treatment, or they got put into treatment, or they're showing up for meetings, or even a yoga class over at the care center. I love hearing that kind of stuff, because then I'm able to take that back to my sheriff, the person that allows me to continue to do this now for almost 2 years. And because he'll say, hey Sue, what are we doing? And I'll say, this is what we got, and here are our success stories.
Oh, that's cool. When people get into public safety, they get into it so they can make a difference. And that's exactly what this program is doing. It's making a difference. I just think it's awesome. How do you interact, if you interact at all, with the PSAP, with the 911 center?
We don't, I don't try to inundate them with extra, call volume, or that they monitor me while I'm out there. So obviously, I carry a prep radio with me, but no, we don't notify them that we go out to the house. It's considered more of like an undercover team or things like that. So it's not something that I inundate them with, that I tell them that I'm out there for this.
Okay. And so if you ever needed assistance, you would just give the address at that time?
At that time, yes.
Okay. All right. And so we know that when you go on these visits, that you have a bag of something that you give them. What's in the bag?
That would be more for Lindsay. She puts the bags together.
Okay.
Yes.
Yeah, I'd be happy to answer that. So in our what we call a swag bag or a care bag. It's a backpack, with a care logo, and then we have a door hanger that gives information all about Macomb County Outreach and what we're doing. It is somewhat confidential, but it's, letting people know that we showed up at their home. So that's either in the bag, and we'll hang the bag on the doorknob, or we'll just put the paper on the doorknob. There's 2 kits of Narcan, so a total of 4 doses of 4 milligrams each. There's an instruction sheet on how I think there's 3 or 4 steps on how to administer the Narcan. There's a resource list and an aftercare sheet of what to do after you've given someone Narcan. There's a fentanyl testing kit with instructions on how people can test their drugs before using. There's a CPR mask with a pair of gloves. There's a small hygiene kit with toothbrush, toothpaste, floss, I think an alcohol swab, and a Band-Aid. We have hand sanitizer, face mask, a care pen, various swag, but I think the important items are what I already mentioned. And then resources. Like I said, there's a resource list with our phone number, community mental health phone number, different treatment centers, with instructions how to get access to treatment.
Sherry, have we shared with you what Narcan is? I don't know if everybody understands.
Oh, I'm sorry. Yeah.
Oh, that's a good idea. I mean, I'm aware of what it is, but
Yeah, I know, and not everybody may be
Yeah.
aware.
right.
Narcan is a anecdote to immediately reverse an overdose for someone on opioids. And it is used in the field by paramedics when they go on a emergency call, a 911 call, and actually they are able on scene to reverse an overdose. And because of the opiate crisis nationally, this drug, it's medication, has been more available, and people are educated on how to use it should there be an overdose in their home or wherever. And so we have received authorization to provide this now outside of just the emergency settings or within the hospitals. There are some pharmacies that actually have it, and you can get it from there too, which is unusual. So that's what it is. And the whole harm reduction thing is always something that people don't totally understand. Why are you giving people who suffer from addiction, this tool to, overdose and then, get back, be able to come back. And it's really about safety and trying to save people's lives, because people are going to use regardless. So that's always been a bit controversial.
There's a couple of questions I had in the swag bag. Are there instructions on how to use Narcan?
Yes, there's a 3 or 4 step, easy, large print, so someone can have it out while they're administering the Narcan.
Okay. And then you mentioned a CPR mask and gloves. Do you provide hands-only CPR, like a quick overview card or something?
I believe that is part of one of the instruction sheets.
Okay. I just thought it might be good. So
One of
you
the
guys,
first steps is that they call 911, and I
Right.
do know from experience that dispatch will instruct someone how to do CPR while they're on speakerphone as well.
yes, I'm aware of that. So Sue, I have one more question for you.
Okay.
So the program started in 2019. You're going on 2 years now. You must have some really rewarding stories and probably a few disappointing stories. Can you share one of those with us without divulging any private information?
Sure. The most disappointing an upsetting story to me that comes to mind is we conducted an outreach and the survivor was not at home. Then what we'll do is we'll go ahead and we'll leave the backpack with the resource bag. We'll leave it usually on the doorknob or somewhere where they can see it, so when they can come home, they can access all that stuff. So we went ahead and left the bag. And then when I came into work the next day, the same survivor had overdosed again. When we followed up on the phone with the parent, we said, well, what happened to the Narcan that we had left on your door? And the parent had said that the survivor sold it. So that was very upsetting to know that they sold it, and it was not at the house for use. And then come to find out, the survivor was actually on a ventilator at the hospital. So that is one of the worst stories, outcomes that we had. So, so that was not a good one.
No.
So after that, we had sat down and we had discussed, well, how do we prevent this from happening again? How do we stop the sale of the Narcan that we're handing there? So we decided that we would try to flood the area of patrol as best as we could. So we're trying to get the Narcan out there. And so that way you take the value of it down. So we try to get as much of it handed out to businesses, places like churches that have, centers or whatever, warming centers, things like that. We'll try to flood our jurisdiction with as much Narcan as we can. We hand it out here at the Macomb County Sheriff's Department when they get released. And that way it takes down the street value of it. So if a survivor were to go sell it, they wouldn't get anything for it. Maybe then they'll think twice and keep it at home.
Right. So I know I said just one story, but can you share us a memorable, rewarding story?
The most memorable was the team went out to speak to a survivor, and the parent had answered the door. Come to find out that both children were in addiction with opiates. She was standing there crying on the porch, that the family had hit rock bottom, and it was a numerous household with a lot of issues going on there. And then basically that was one of the days where, both of my team members got hugs, and the parent had said, thank God for you, for the team, that you came out here today. And she said, you guys are angels, and that I'm glad you were here to give me hope today.
Oh, that's nice.
Mm-hmm.
Is there anything we missed, Sue, that you'd like to discuss?
Well, in the beginning, so when we go out, just to know that I am not in uniform. I don't know if we did discuss that. That was part of it. I am just in regular street clothes. CARE usually has their entity on, they wear a t-shirt or a polo shirt, and then the paramedic as well represents MedStar. So that way, again, when they see that we're just not three people walking up to their door selling something or Girl Scout cookies or whatever, they can actually see that, we're represented, so that we do gain that acceptance right off the bat. And like I said, when I introduce the team, we go with first names, and I never tell them where I'm at till the end. And that's kind of the best part too, is at the end when we go to say goodbye, we're shaking hands, we're giving hugs or whatever, however it's going. Then usually Lindsay will look over and say, well, just to let you know, Sue here is from the Sheriff's Department. And then we kind of get that shock and surprise, because again, this is a non-arrest program. Even if they have a misdemeanor, we will not arrest them. If they were to want to hand us over drugs or anything at the house, I will not arrest them. This is a non-arrest program, because the minute we arrest somebody, all of our credibility is gone.
Right.
So we are there to help them. not create any conflict. So it is kind of different to see the shock and surprise on their face that a law enforcement officer had been standing in their house for over an hour trying to, being compassionate and understanding their plights. So that is part of the program as well.
Well, I just want to thank you for being part of this program and extend our gratitude also to Sheriff Wickersham for supporting it. It's just really sounds like a great program, and I'm really happy that you guys are doing this. I hope it spreads.
I do as well. Hopefully this program continues and we continue to grow, and more of our surrounding jurisdictions will get on board, and that is my hope for it for the future.
All right. Well, thank you. I think we're going to transition into Lindsay.
Okay, hi.
Hi, Lindsay. How are you?
I'm doing good. How are you?
I'm just fantastic. Actually, Lindsay, so I really wanted to get into like what CARE does, because what you talked about yesterday just sounds like an amazing approach to what people nowadays like the life coaches and the wellness 360 approach to what you guys do. And I'm curious as to what do you guys look for in the individuals you hire to be coaches? What does a coach look like, and what do they do, and what do you want to see in them?
Yeah, that's a good question. Our obvious, I think the most obvious and utmost priority is that they are someone who is in recovery from substance use disorder, and that is 2 or 3 or 4 years. Each department, depending on the funding and those requirements, they can have 2, 3, or 4 years in recovery. I personally will have 7 years on the 28th of this month, and a lot of our coaches, are well past the 2-year mark.
Wow.
So yeah, that's most important, and then have lived experience in recovery, so they know one or more pathways to recovery, whether that's 12-step or something else. And that's really what CARE focuses on, is that there are multiple pathways to recovery. And I mean, I could talk for hours on the different pathways, but just know that there are many. We do know that AA is most common, and we know that program works for millions of people, but there's also millions of people that it doesn't quite work for, and so we fill that gap by offering resources to to what interests the individual. We offer person-centered care, so when I'm working with someone, will never define recovery for them. I'll ask them what recovery means to them. What is unmanageable in your life, what's making your life unmanageable, and what do you think recovery would be for that? And based on that definition, because of my knowledge and experience in the different pathways, I'll make some suggestions and offer resources and get them connected to the recovery community that works for them. And if they try it out and maybe that wasn't quite the right fit, we'll try something else. And I'm with them every step of the way.
So, can you explain a little bit on how you got became part of the CARE family, and how you joined them, and why you continue to work there, and what you like about it?
Oh, sure. I like that question. I was actually bartending, working at this awesome restaurant in Ferndale, and someone that is really close to me in my recovery, my husband and I are close to this person. They worked at CARE, and at the time I did not know what a peer recovery coach was. By that point I had been in recovery for 5 years. Everyone I talked to is in recovery, but I didn't know necessarily like the professional side of recovery. And so I was kind of getting over being in the service industry, and our friend was over one day and said, "Oh, CARE is hiring," and I asked him about what does a peer recovery coach do, and he told me, and it sounded really great. I mean, I think everyone in recovery will tell you that what they want to do most is spread the message of hope, that, to tell people that life can be different. And so I applied at CARE, and I went through their two interview process, and was hired and started working in the emergency department of several Macomb County hospitals, which was an amazing experience. I worked alongside the doctors, nurses, social workers in the ER. So that is anyone who comes into the ER who had an overdose or is intoxicated or going through withdrawal. Once they're stabilized, I would be invited to sit with them and introduce recovery options. And we, got a lot of people to go to treatment that way. And I've been with CARE since 2019, and now I'm a program supervisor of the Recovery United Community Center here in Fraser.
No, that's just incredible. And you're saying that every one of the peer coaches is also in recovery, and that's just an amazing point that I wouldn't even honestly thought of myself. This is kind of an interesting question. If you had like a magic wand and you could add something to the Macomb Outreach Program that they're doing right now, or one thing you think would be beneficial, what do you think you want to see added to it?
Oh, well, I think like Sue and anyone on this call would agree is to just have more opportunity, reach into more cities. I mean, Macomb County has, so many overdoses at an alarming rate, like at, most places across our nation right now, and we want the opportunity to respond. We have the resources in terms of peer recovery coaches, and we have this team which is so unique, and I'd love to just be able to have more teams that exist in responding. We've seen so much success, and it's such a holistic approach, and it really works. So I think being able to go into more cities, being able to have more teams working together and expanding this, that's what my magic wand would do.
No, that's awesome.
And Zach, if I just might add that, I agree totally with Lindsay, and we really continue to reach out to other municipalities in the area to join our program. But we've actually talked, Andy Brown and I have talked about, are there other things we could be doing from a medical perspective while we have these folks captured, if you will? Perhaps, crazy as it is right now with vaccines and that kind of thing, doing things like that in the field, just because oftentimes these patients, these citizens don't have medical care or access to care. Yeah. And so there may be some other medical things we could be doing to care for them. So that's another thing we're considering.
Yeah, that would be amazing. I know I always ask, do you have any wounds that need tending to? And that's such a great thing that we're able to offer on the spot. We can get it cleaned up right now. Yeah, Debbie, vaccines, that would be incredible.
So actually a question maybe for both of you, kind of touching on the topic, maybe Andy can get involved in this one as well. When you're able to perform those like on-site, like checking for wounds or the vaccines or stuff like that, I feel like it almost kind of pertains to, providing the narco to individuals as well, because you're providing a medication outside of a doctor's office or a medical facility. How hard was it to actually integrate a program like that? Or because you had because you work with MedStar, it was actually an easy transition?
Well, I can start, and then maybe Andy can add to this, but, we got special permission from the state of Michigan. Remember, this is a special study to do this. And you said narco, and it's really Narcan, because narco is actually a controlled substance. No, that's okay. That's okay. We're all learning, honestly.
Yeah.
And so honestly, the the community paramedics are still working within their scope of authority, if you will. But if we were to add something to it, whatever that may be, whether it's vaccines or whatever, we would have to get permission if it was outside of their normal work. And if it makes sense, I mean, in EMS right now, we're doing lots of non-traditional things, including administering monoclonal antibodies to patients in their homes that usually are done by personnel in the hospital or in an infusion center or something like that. And so the traditional responsibilities for a paramedic have been changed just to meet some of the needs right now. So because this is a special study, it's as simple as, requesting permission from the state. And of course, it has to go through a process of physicians reviewing it and all of that. But, for some of these things that make sense and promote health for people who don't necessarily have access is usually looked upon favorably.
Okay. Andy, I have a couple questions for you regarding the term you used the other day was proactive community paramedic. Can you maybe describe for me what the difference is between like a proactive paramedic and a reactive paramedic actually on the field, and what you look for in terms of who you have on type of what responsibilities?
Absolutely. So the term proactive community paramedic medicine really is an approach to providing service that is not traditionally seen in a very reactive system as EMS typically is. The 911 system is very reactive in nature because someone is calling the system and requesting a help for a number of things. Obviously, breaking and enterings, violent crimes, injuries, fires, what have you. So we're always reacting to that request in that sort of environment. The community paramedic program is proactive because it's identifying areas of need, whether that's in populations like folks with suspected use disorders or patient clinical criteria that we have found to need additional assistance with understanding their care plan that has been provided to them. And when we talk about identifying those populations of need, we're able to develop a care plan or a system of protocols that will allow us to provide that gap in the care that they need. So we talked a little bit in specifically relation to the suspected use disorder program or the opioid response team, is that when our paramedics enter the home, they're looking for any emergent situations. We always want to make sure that there isn't some pressing emergent underlying condition of the patient that is going to require an emergent transportation to a hospital. But once we've done that, then we're really able to dig in more to the social determinants of health. Do they have access to vaccinations? Do they have as Lindsay mentioned, the Narcan kit? Do they have BBMs or CPR masks available to them? Do they have all these tools that could potentially intervene in a life-threatening situation? And I think when we talk about a proactive approach to paramedic medicine, we're talking about really giving the population that we're trying to impact the tools to be healthier, the tools to live a healthier, safer life. And that's really where the value of our program comes into play, is that, it doesn't have all the excitement of, driving an ambulance or a fire truck, lights and sirens to a call and all the glitz and glamour. But it really has an impact on the communities that we serve, because we're preventing that. We're preventing that emergent call from coming into our system, and being able to impact these people's lives in a way that really is probably more impactful. Because we're teaching them the value of following their care plan, of making sure that they have all of these needs met prior to them calling upon the 911 system. And that's really where the value of a proactive community paramedic program comes into play, is reducing that risk of an emergent situation ever being called into play in the first place.
Now, with your paramedics on the field, do you have certain individuals you have working in that proactive side of it, or is it kind of like you pick up people where you are just because of staffing purposes?
So there's multiple designs, but for the MedStar design, we have specific paramedics that are not working in an ambulance. They're not on a normal shift. They have been pulled from that side of our operation. They've been provided significant additional training in order to be able to perform these skills. And typically, what you see is that it's the paramedics who have been paramedics for quite some time.
Mm-hmm.
It's paramedics who have had all their fun out on the road. Now they're really understanding that there is more that they can do in their career and in the communities that they serve to provide assistance to those in need. And I think the one thing that it has always been such a moment of a position of pride for us is that they take it to heart. They really have bought into the program. They understand. They are so compassionate. They live and breathe this program. All first responders live and breathe their job, but I mean, it really takes a special kind of person to perform in the role that we have asked our paramedics, our community paramedics, to perform in, because it puts you in a position where you really are immersing yourselves in the lives of the people that you're interacting with, the patients that you're interacting with, and it's not, psychologically, it's not easy to detach from that. When you are invested emotionally with these patients and you see them on a regular basis, you start to assume some of their burden. You start to assume some of that emotion with these patients.
Right.
In retrospect, it's, when you look at the ambulance side, you're maybe with a patient for 15 minutes and you drop them off at a hospital and you may never see that person again. So it's a little easier to detach psychologically from that. But, we have 7 paramedics in our program right now, and they know their patients by name. They know their patients by heart. They know the family members. They immerse themselves so much into the communities that we serve and the patients that we see, that it really is a special program. And that's why I'm so happy and so proud to be part of this team and hear their stories and see the impact that they're able to have, because it truly is. It's not a big group, but it truly is a very special group.
No, I agree with you. The team sounds amazing. The program sounds incredible. Can you maybe touch on, as much as you can, a little bit on the extra training that those type of paramedics do require?
Sure. So they're all paramedics, so they all have to go through the normal curriculum that all paramedics have to in the state of Michigan, which is about an 18-month program, give or take. And then for our paramedics, we put them through training that is provided through our accredited training program, and it is based on, as Debbie mentioned, the protocols that have been approved through Michigan Special Studies. And we are still very tightly, I should say, governed. So we have very specific skill set that we train them to. We put them through, obviously, lecture courses, but we also put them through lab courses, so they have hands-on experience with the protocols that they are being trained on. And the program initially, the training program took about 8 to 12 weeks to get everyone through. And then obviously, as Debbie mentioned too, as we keep adding in protocols that have been approved, we provide that additional training as well. So it was about an 8 to 12 week initial training, plus any additional training that we have to provide for our staff for any new clinical protocols or clinical skill sets that we teach them.
Oh, I understand. That sounds amazing, especially because it comes from the Michigan. You said a Michigan approved studies. Was that the group it was called?
Yeah, so it's protocols that are approved through the Michigan Department of Health and Human Services through a special study.
Okay.
And the nice thing about it, and not to get too far off on a tangent, is that's those protocols are going to expand greatly here very, very soon.
Awesome.
The state is actually expanding the education the approved education for these programs in a far more comprehensive clinical way than we have seen in many years. So that's really the next, when Debbie and I talk about what's next, what can we do next in our communities, the expansion of the education, the expansion of the skill set that is on the horizon is really what's putting us in a position to start considering some means even beyond what we're able to do now.
Correct. No, I gotcha. So then, Andy, from the paramedic side, and maybe, and we had asked Lindsay the same question before, can you maybe tell us one of your personal triumph stories that you know of, or maybe some even disappointing ones, without giving out too much information?
Lindsay, do you want to take the lead on that?
Yeah, of course. Well, one of my favorite stories, and it's ongoing, which is great news. We met with someone, let's see, it was about 40 days ago, and it was an ideal outreach situation, right? Everyone was home, parents were home, survivor was home. I met with the survivor in private for about 20 minutes while Sue and the paramedic spoke with family, which is a really nice dynamic that they can offer support to the family while I'm meeting with the survivor. The survivor was very receptive. Her experience with her overdose, really scared her and jolted her to want to motivate her to make some changes. And the next morning, like I said, I supervise a whole recovery center where we offer all kinds of different groups, recovery support groups. And so the next morning, the survivor showed up to our all-women's meeting, and she's been coming here multiple times a week for various groups. We have an art group that she loves participating in. I'm her peer recovery coach, so I meet with her one-on-one, face-to-face, at least once a week, and we have phone calls, and there's real healing taking place. She's, building a foundation in her recovery. Yesterday was 38 days for her with absolutely no substances, which is huge. I mean, it's monumental when people decide to do something different, right? To make a new habit. And so, we met face to face, and she was so excited to tell me, she's counting her days, and and then she stayed for one of our later groups. So she's fully engaged, right? And that's a huge success. Another success in my eyes is just when someone answers the phone. When I do my follow-up phone calls after trying to reach someone in the community, and they just answer the phone and they're receptive. And it's always really my experience since I've been part of the team is we're so grateful that you showed up. We're so grateful that you care enough to actually do a home visit, whereas people might be scared that nobody wants anyone to show up on their doorstep, but actually it's been quite the opposite, which is great to see that this is something the community does want. So,
Lindsay, I have a quick question for you.
Sure.
You mentioned doing a follow-up. How long do you continue with them after the initial visit?
Yeah, so I can, within the outreach program, we meet for people who want to engage for 90 days. But if they're wanting to continue working with a coach, it's just a quick referral process into another department where they can work with a peer recovery coach for a year. And we do. We work with a lot of people for longer term. And we're meeting with them once a week, and then maybe after a few months it goes to once every 2 weeks.
Okay. So one thing I want to actually discuss with really with all of you, because this program really sounds like it's designed to bring back a foundation that's been lost in somebody's life, right? Whether it's with the public safety department, with the healthcare industry, with really just the emotional other individuals, and CARE, Macomb Sheriff, and MedStar are all kind of coming together to provide that base, that foundation again for somebody. Where do you see this type of program going? And I know you say you want to spread to other types of cities, get other things in there. Is there another form of department that you think bringing on another group that bringing on might make another big difference for individuals' lives?
I'll take a stab at that first, if I could. I don't know that we would add any other department, but what I do know is that as we make these visits, it appears that oftentimes things are different and needs are different. So we may partner with a group to provide resources for these individuals. You know, we didn't really know initially that a dentist would be that important to a patient or somebody that we saw. So we have dentists who will actually see these patients for free to provide care to them. So we've learned along the way that, there may be other resources that may be appropriate, and we partner in that way. That's from my perspective. Now, I feel like you don't want to get the group too large because it may be more intimidating. On the other hand, I think the resources needed, and it's interesting because there are people, doctors, dentists, other community services that are actually very interested in helping others that maybe we thought they may not be able to accommodate in some way. So, I would say that. The other thing I guess I would say, I'm a retired hospital administrator, and I kind of got out of the business about 7 years ago because everything was moving from the hospitals into lesser expensive environments to provide care. And one thing, more things are moving to outpatient or into the homes. So I think a program like this is actually, I say a thing of the future because it's just different. It's more community based. Yes, patients do still go to the hospital, but oftentimes they don't need to go to the hospital anymore when we're providing this kind of service, whether it's in the field or through the community or that kind of thing. So that's what I see, programs more like this growing in that way. And that's just my perspective.
Okay, so almost like not necessarily adding other resources, but on the as needed basis, like you said, with the dentist and all that stuff. And maybe Lindsay might be able to answer this. Do you know of like another maybe break in a foundation that might be there that might be impeding people's willingness to engage with the program?
That's a really good question, and trust me, I've spent a timeless amount theorizing about it. I think, because you asked me, my opinion is that one of the largest barriers is just fear and like lack of connection to other humans, lack of connection to a community. And so the Macomb County Outreach is such an aid in that because we are bringing community to them. And once they meet with a peer recovery coach, like Debbie was saying, all the different resources that someone may need, we bring that to the table. We connect people to whatever resource. I mean, I think I said it earlier, peer recovery coaches are also known as resource brokers. And we'll get them connected. And it's not just giving someone a phone number, it's knowing the systems, knowing what someone needs to say. Someone who is actively using might not even be emotionally or mentally equipped to pick up a phone and make a call. And I mean, we've all been, had to call the internet companies, Xfinity or Comcast, and what a pain that can be. And, if you're not emotionally or mentally or had your coffee for the day, you're hanging up the phone. We will sit with someone and, figuratively hold their hand or just be there and coach them and guide them so that they can make the doctor's appointment that they've been needing to make for years, or make the call to get into treatment. The call to get into substance use disorder residential treatment can take about 45 minutes. Can you imagine withdrawing from substances, having to be on the phone answering questions for 45 minutes? It's not the easiest process, and so having a coach be there is super helpful, and it gets people connected.
That's such an important point, because you are so right about that, because they will just give up. In addition, we have given people rides to where they need to go, because oftentimes they don't have transportation and that kind of thing.
Exactly. I will say, if I may, being a peer recovery coach, and someone in long-term recovery has really reintegrated myself into society, beyond just my recovery community. I love, and I'm being so honest, love working with MedStar paramedics and Sue and Ken, and I might not have said that, a few years ago. So this team is also helping me, and I think the individuals who are part of it, and I just, want to take that opportunity, Zach, to say that. So thanks.
That's awesome.
And we think you are a rock star, Lindsay, so thank you
thanks,
for
Debbie.
your contribution, because honestly, it wouldn't be as meaningful without care, and actually you, a person like you, truly, because it makes a difference when you understand even to a deeper level than all of us, and people trust you. You are the one who initiates that trust for all of us, so we really appreciate that.
Thanks, Debbie.
Yeah, I wanted to add to thank you for your vision for such a great program and your wisdom on how you were going to put the program together. You guys are leaders in the industries, and you're really making a difference, and we are very grateful, and really, truly also appreciate you being here with us for our podcast.